All right, everybody. Hey, it's Reed again. So I'm planning on doing with this video is we're just going to go through a lot of EKGs. I'm going to show you how I approach EKGs, and going to do that for 100 either EKGs or rhythm strips. So just pulling up my screen here. Now I've got screen sharing is on, and let's get started. So first thing is this EKG. And actually, what I'm going to do first is I'm going to just go through my approach to EKG. And so first thing I do is I look at the overall rhythm. And I determine, is it regular? Is it irregular? What do the QRSs look like? Are they wide? Are they narrow? Do they have a certain pattern to them or morphology that might stick out to me? The next I'll kind of go top down from a heart perspective. Where do we start with the heart? Well, sinus node and our P waves, and I'll determine what are the P waves doing, how are they behaving, are they associated with the QRS complex, are they sinus in nature, and then I'll start measuring intervals, PR interval to look at my AV node. I'll do QRS to start looking at ventricular activity. I might take a look at the QT just real quick. I'll take a look at my QRS complex itself and make sure that ventricular depolarization is in a axis that is appropriate, and that the morphology of the QRS throughout all the leads is what I expect it to be. Then I'll go through ST and T segment, put it all together. Because we're doing so many EKGs, I'm not going to maybe explicitly state everything that I do in that regard, but we're going to just roll and see what we can do. So we'll start off with this EKG, and I'm going to look at the forest. I've got a regular rhythm. I say the rate is 300, 150, 100, maybe somewhere between 75 and 100, maybe 85 beats per minute. Okay, and then can go and take a look and see what my sinus node is doing, see if I have P waves, and yes, I see P waves. I see P waves for these, but are they sinus P waves? And if you look here, it's up in one, it's up in one, it's up in AVF, so I'd say that's sinus. This is a sinus rhythm. Okay, let's see what our AV node is doing. I don't see a block. I see that's less than 5 boxes in the AV block. But my QRS is definitely wide, and so my differential for that is maybe a bone branch block. And in my lateral leads, I see this RS, R prime, lateral leads, RSR prime, RSR prime, RSR prime, and I see deep S waves, slurred S waves in V1 and V2, and so we're getting late forces in lateral leads, and so this rhythm is a normal sinus rhythm with a left bundle branch block. So same thing. Let's look at the trees. Got a regular rhythm, looking pretty slow. So let's see, 300, 150, 100, 75, 60, 50. We're probably somewhere in the 30s. Somewhere in the 30s. Okay. So we've got a bradycardia. Well, we need to have a differential diagnosis for bradycardia. It could be an AV block, it could be sinus bradycardia, it could be a junctional rhythm. And so let's take a look and see what we can find. So let's look at the atrial activity, and I start looking. I see this P wave, and I see some P waves. Yeah, there's definitely some P waves that are not associated with QRSs. P waves that are not associated with QRSs, and if I look closely, and your eye will get better, you'll start seeing P waves that are buried in places that they shouldn't be. you can even see a P wave on top of that T wave. And the reason why I know that that is a P wave buried in that T wave is I compare it to the previous T waves. Compare it to other T waves of that same lead, and you don't see that little intense notch. And so I've got P waves that are marching through, so the atria is beating, and we know that they are sinus P waves because they're up in 1, and they're up in AVF, and so the atrial depolarization is what it should be, but it's not communicating to the ventricles. And we've got this very slow 30 beats per minute narrow complex. So if it's a narrow complex, we know it's going through the junction, through the His-Purkinje system in order to rapidly depolarize the ventricles. And so I might think that this is a junctional escape rhythm. And so a junctional escape rhythm would occur if a person had a complete AV block or a third degree AV block. And that's because the AV node is not conducting, and the junction, the AV junction, is having to take over that rhythm. So this person has a third degree AV block. Same thing, let's look at the trees here. That's regular rhythm. Our rate somewhere 300, 150, 100, maybe 80 beats per minute. Okay. And let's see what our sinus nodes are doing. I've got P waves that are up in 1, they're up in AVF. So this is a sinus rhythm. Our AV node, it's less than 5 little boxes, so no AV block. Got a narrow QRS, that's good. That's up in 1, it's up in AVF, so we know the axis of the QRS is going down to the left. We've got good R wave progression as we go from V1, V2, V3, transitions here at V3, so that's appropriate. And then we get R wave transition. When I look at the QT, one of the things I look at for the QT is I'll look from R to R, and if the T wave does not, if it ends previous to the halfway point, then you can kind of eyeball and say that the QT is good. It's just the eyeball test. And you can obviously calculate the QT interval if you would like. But we're not going to be doing that really today. And so we scan, we look at all the anatomical leads, we look at maybe the lateral leads in V5, V6, and 1, and AVL for ST changes. I don't see it. We might look in the inferior leads. I don't see any ST or T wave abnormalities, septal and anterior leads. And so this is just a normal sinus rhythm. So our next case, we have a rhythm here. Let's take a look at lead 2, and I'm ticking away and see some normal QRSs here, but there are some kind of bizarre looking beats. Beat, 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 weird. And so I'm like, okay, that's kind of interesting, but let's not focus on them yet. Let's look at the rest of the strip, because these look normal. We've got P waves in front of them, and we can go up to our strip. We see that they're up in AVF. We see those P waves. Kind of hard to see it, but it's not flat, or it's not positive necessarily, but it's flat. So these are probably P waves that are going straight down. So I'd say it's a sinus rhythm. And might look at our AV node conduction. Looks like that PR interval is maybe right at 200, so we're borderline first degree AV block, but we're going to give them the benefit of the doubt. We're going to say it's not the first degree. And so then we're going to look at our QRSs that are in our normal beats, and those are narrow. And it's up in 1, it's up in AVF, and so that's a normal axis. We've got good R wave progression here. And the precordial leads. And so now let's try to figure out what these little funky beats are. And we see that these funky beats are wide. They're greater than 120 milliseconds in width. And if you look in front of them, I'm going to use this one. If you look in front of them, I'm looking for atrial activity. And so I'm going to compare the T wave of the previous right here to this T wave and see, do I see any P wave buried? Because sometimes if a P wave was somewhere right in there, it would be the cause of this QRS, but I don't see any differences. So I don't see any P wave. I don't see any atrial activity that is driving this premature beat. Same thing here. And so these would be PVCs, which would make sense because they're wide. Remember, PVCs are from the ventricular myocardium, and they don't take the highway system throughout the ventricles. They're wide and they're pretty mature. They're happening early when you look at the R-to-R intervals. They're happening before the next beat should occur. So those are premature ventricular contractions, and the morphology is the exact same every time. So we know that all of these PVCs are coming from the same spot in the myocardium. So you could even say that these are unifocal PVCs. Right. The next EKG, we're going to look at this rhythm strip here, and I've got a quick rhythm, but it's a pretty short interval compared to this is long, and then shorter, maybe a little longer. So it doesn't look very regular in a sense. So maybe we're gonna think, well, what could be some irregular rhythms? It could be an AV block, it could be PACs, it could be AFib, it could be A flutter. And so I'm gonna look for atrial activity, and I don't see any atrial activity. This is a narrow complex QRS that we're looking at. So we know that narrow complex QRSs are coming from the AV node. If that's the case, then this must be an atrial arrhythmia. I don't see a pattern to it. I don't see any good P waves before QRSs, and so I'm be pretty confident that this is AFib. And the rate ranges anywhere from 300, 150, 100, 75, maybe 55 beats per minute to 300, 150, maybe 120 beats per minute, anywhere from 55 to 120. I would say if you wanted to, you can count over 10 seconds or over 6 seconds how many beats that you see, and multiply that by 10 to get how many beats per minute this would be. But I would say this is not necessarily a rapid ventricular response, and so this is AFib with a normal ventricular response. Well, it's not done. We need to evaluate the QRSs, and so we see the QRSs are up in 1. They're up in AVF, so we know that the QRS axis is down to the left. Remember, AFib is originating from the atria, but it's still traveling through the His-Purkinje system like normal. We can still evaluate for ST changes. As I scan through this EKG, I don't see any ST changes. I don't see hypertrophy. I don't see bundle branch blocks. Those are all things that you would still want to evaluate for in a patient with AFib, because the atrial is fibrillating, the ventricles are depolarizing in a normal fashion. Yeah. Alrighty. So our next case here, let's take a look at it. I've got a regular rhythm here. I've got a rate of 300, 150, just under 100, maybe 98 beats per minute. I've got upright P waves in lead 1 and AVF. I've got a normal PR interval. So my AV node is doing well. My QRSs are narrow, but I see some higher amplitude over V6 and V5. And I see some very negative amplitudes in V2 and V1. And so I might think maybe this person has some ventricular hypertrophy. And since it's the lateral leads, I would say that this might be left ventricular hypertrophy. And so I'm going to count. I'm going to say 5, 10, 15, 20, maybe 23 millimeters is our R wave in V6. And I'm going to add that to our S wave, which I'm going to say maybe ends there, starts there in V2, and 5, 10, 15, 20, maybe 25. It's our S and V2, and so that is 48 millimeters, which is greater than 35 millimeters. So I would say this person has ventricular hypertrophy. And so this patient has a normal sinus rhythm, left ventricular hypertrophy. Right. So this patient, well, we're gonna do the same thing. We're gonna look at the rhythm. It's regular, narrow, complex. And let's see what the atria is doing. We've got P waves in front of our QRSs that are upright in 1, upright in AVFs. This is sinus rhythm. Our AV node is conducting this signal right at about 200 milliseconds, maybe a little longer. Let's find a QRS that starts right on the thick line. So I would say this one right here starts pretty on that thick line. Maybe right at 200. You could argue this is a borderline, and maybe in lead 2, right there to right there, you could say that this is maybe 220 milliseconds. So you could say maybe a first degree AV block. Okay, so it's our AV node. But there's no drop beats, they're all always marching along, so it's a first degree. We've got a narrow QRS, so we know that the ventricles are conducting appropriately. We have isoelectric QRS and AVF, and so if AVF is pointing downward, isoelectric would mean that the axis of the QRS is somewhere perpendicular to that. And because it's positive in 1, we know it's going to the left. So this might be leftward axis, but not left axis deviation. And so this is, there are some hemi blocks that could cause this, but we're not going to go into that. And so really what I want you to get is this person might have a borderline AV block. I'm not going to go more in depth into what we see maybe with the QR in lead 1, the RS in lead 3. And so, yeah, maybe first degree AV block. This patient, let's take a look at the rhythm. I see a rapid rhythm. I'd see it's kind of maybe not regular. Look at the RR interval here compared to the RR interval here. I would say it's different. I would say it's definitely different amongst this. So we need to figure out why that is. But first, let's just use our reasoning. It's a narrow, complex tachycardia. So if it's narrow, that means it's likely coming from the atria in some origin. And so let's take a look and see what the atria is doing. And this rate is ranging between 300, 150, 140 beats per minute to 300, 150 to 100. So somewhere between 100 and 140. Now look at the atrial activity. I see P waves. But if you notice, these P waves don't look the same. This P wave and this P wave looks the same. Looks the same as this P wave, but it doesn't look the same as this one and this one in morphology. This one is negative P wave. This is another negative P wave. This is a less positive P wave, and then you have a couple of the same, different, 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 different. And so there's at least 3 different P wave morphologies. And when you have 3 different P wave morphologies, that's telling us that the atrial rhythm, the impulse that is spreading, the depolarization of the atria that is spreading through the atria, is happening at different points. It is multifocal. So this would be a multifocal atrial tachycardia. Notice the QRSs in multifocal atrial tachycardia are the exact same, because no matter in what direction the atria depolarizes, the AV node is going to capture that signal in a normal fashion, pass it along to the ventricles. And so here we have narrow QRSs, and it's okay. That's what we would expect. And so when you look at the axis of this QRS, it's down in one and it is up in AVF, so that means it's going down to the right, so we've got right axis deviation. And this patient has something called a left posterior hemiblock, and that's not something that I'm going to really go into in this lecture. But that's left posterior hemiblock is what's likely causing the right axis deviation. And so, big thing to take away is just multifocal atrial tachycardia, and that's why these QRS complexes are still nice and narrow. Yeah. So, next slip, we're going to look at the rhythm again. And as you can see here, we've got pretty slow and then fast maybe, and then we're going to pause. And, okay, it's interesting. I would say this almost looks maybe like group beating. We have group there, we have a pause, and we have a group here, and group beating makes us think that perhaps this patient has an AV block. And so what's the H rate doing? Well, we've got some P waves, and those P waves are up in lead one and up in AVF, so these are sinus P waves. So let's take a look and see, are they conducting to the QRSs? So I've got a normal AV node function on this beat, and then maybe it's a little longer there, maybe it's a little longer there, and then we have a P wave that does not conduct to a QRS, and then we have it kind of reset, and we have a normal PR, and then it gets longer, and then it gets longer, and we have another one that doesn't. So because there are some that don't connect, we know this is second degree, and because the PR interval is getting longer and longer until it drops at the type 1 or Winky Bach. And so maybe that's an H, I can't remember. So we have a second degree type 2 or type 1, and then what we're going to do is we're still going to need to evaluate the QRSs because this is just telling us what the AV node is doing. It's not telling us what the His-Purkinje system and the ventricles are doing. And so I see narrow QRSs, and I see a QRS that is predominantly up, maybe isoelectric in 1, maybe isoelectric. And so if it's isoelectric to 1, it means it's going to be perpendicular to 1. It's up in AVF, so we know it's going to be down. So right at about 90 degrees for its axis. And we don't see any ST or T wave abnormalities in this. And so this is a sinus rhythm with second degree type 1 AV block. All right, next EKG. We've got going to do our, looking at the trees here. Got a regular rhythm. It looks maybe a little bit slow. So let's count it. We've got 300, 150, 100, 75, 60, 50, maybe around 40-ish beats per minute. So that's a bradycardia. Well, we know that bradycardias have a differential in themselves, and so let's see what we think. Well, I see some P waves, and those P waves are up in lead 1, they're up in AVF, so this would be a sinus brady. I don't see any P waves kind of hiding in between the R to R interval to make me think that this would be an AV block. And so in this patient, I would continue to see the PR interval looks good. They've got narrow QRSs that are up in 1 and up in AVF. And so we know the axis is somewhere down to the left, which is between 0 and 90, positive 90 degrees, which is normal. I've got normal R wave progression throughout the precordium. And so I would say my QT interval, it's getting closer to being on the longer end. And you can calculate that and see if you would like. This is a good example of sinus bradycardia. Next EKG here, we're going to look at a rhythm. It's fast, it's regular. Let's count the rate. I like to find a QRS that lands on solid lines, so maybe 300, 150. This would be 100, so maybe 130 beats per minute. So it's fast. And so let's see if there's a P wave, and I see P waves right here. Those P waves are up in one, they're up in one, they're up in AVF. So I'd say this is a sinus tachycardia. Okay. So we said it's a sinus tachycardia. Is the AV node working well? Yeah. It's a good PR interval. There's no drop beats. And so the QRS is narrow. So let's take a look at the QRS axis. QRS is up in one, so it's going to the left. And it's down in AVF, and that's the QRS. And it's down in AVF. And so you could say that this is going up and to the left. If it's going away from AVF, it's going up and to the left. This would maybe be left axis deviation. There's some things that cause left axis deviation, and this might actually be a hemiblock. And so we're not going to talk about that. And so I'm going to continue to scan through. We looked at our QRSs, but if you look closely, we've got some ST changes. We've got some ST depression in 3. We've got some ST depression in AVF. We've got some ST depression in 2. So those are inferior ST depression. We've got in the lateral leads ST elevation. In the lateral leads ST elevation. And so we've got, let's see, some ST depression in V1. We've got, so we've got elevation in some of the lateral leads and depression in the inferior leads. And so this will be concerning for likely a lateral ST elevated myocardial infarction, and as evidenced by, and these are probably some reciprocal ST depressions in the inferior leads that we're seeing. Next EKG. So we're going to go through, we're going to look, the rhythm is regular. We're going to do our rate, 300, 150, 100, maybe 80 beats per minute. Is it a sinus rhythm? Well, we've got P waves that are up in 1, that are up in AVF, so it's sinus rhythm. We've got an AV node that is functioning with a normal PR interval and there's no drop beats. We've got a narrow QRS, and the QRS is isoelectric and AVF. It's up in 1, so the axis of the QRS is right about 0, which would be normal. So let's say that axis is 0 degrees. And so when I look at some of these STs and T waves, if you look at V1, we'll say V1 right here, we've got maybe some ST depression. And if you look at V2, we might have some ST depression. And then we've also just got T wave inversions in those same leads. So this might be concerning for some septal ischemia based on the distribution anatomically. Otherwise, our T waves, our QT interval does not seem to be prolonged, maybe borderline. And so I'd call this a sinus rhythm with some depression, V1, V2. And you could even say, just a little bit, that it's hard to say, but there are some pretty big R waves in V1. Might be concerning for RVH, or it could be concerning for a hemiblock of some sort with this RS and lead 3. But regardless, we've got a sinus rhythm here. Some ST changes that are probably important to note. Alrighty, so our next rhythm, we're going to take a look and see our regular rhythm. Okay. And the rate here is going to be 300, 150, 175 beats per minute. Let's figure out what the atria is doing. Well, I can't seem to find any P waves. I don't see any P waves. Okay. My QRS is narrow, or I mean, excuse me, it's wide. It's about 160 milliseconds. And so when we have that wide QRS, it indicates that ventricular depolarization is not happening via the His-Purkinje system. And so this must be some induction throughout the ventricles that is not being driven by the atria. Because we said that if we saw atrial activity, our AV node would conduct that, but here I don't see any atrial activity. But the rate that's 75, and so I've got some type of ventricular rhythm. It's not arising from the junction, because if it was a junctional rhythm, it would be narrow, at least more narrow. And so what we could say about this rhythm is that it is a, we call it an idiopathic accelerated ventricular rhythm. And so that's just accelerated ventricular rhythm. These are ventricular QRSs. And if you look at the rest of the morphology, you might notice there's some T waves. The area under the curve of these T waves is very narrow, and they're much higher than relative to the QRS than we would expect. And so you might think that this person has hyperkalemia, and that could be the cause of this arrhythmia. Alrighty, next. Here we've got a regular rhythm. It's rapid. It's about 300, 150, so maybe 180 beats per minute. We know sinus tachy doesn't go that high. These are wide, complex QRSs. If you can see here, wide, complex QRSs. And if you look closely, what you can see is there's maybe something called AV dissociation, where occasionally when we have VTAC, what you can have is a couple of those ventricular rhythms, beats that are depolarizing through the ventricles, can actually retrograde up the AV node and cause a retrograde P wave. And so what you'll find are maybe some little notches on those T waves that might indicate those retrograde P waves are buried. It's a very subtle finding, but it's actually quite interesting and something that can help you discern. But this is a regular, rapid, wide complex tachycardia, and so you can go ahead and say that that would be a monomorphic VTAC. Okay. Let's take a look at this beat, or this rhythm. So we're gonna regular, seemingly regular, we've got these funky beats that are gonna happen out in the middle of nowhere. We've got normal P waves in front of our QRSs that are up in 1 and up in AVF. So we have a sinus rhythm. Our AV node greater than 200 milliseconds. So we've got a first degree AV block. Right, all of the P waves conduct QRSs. They're just a little long, so the first degree. QRSs are narrow. They're up in 1. They're up in AVF. It's a normal axis down to the left. So let's figure out what these beats are. And if you look at these beats, they're wide QRSs, and in front of them, I don't see any atrial activity. Wide QRS, no atrial activity. Wide QRS, no atrial activity. And why do I look for atrial activity in front of every single one of these QRSs? Because I want to make sure that they're not arising from the atria and then the ventricles are conducting that signal down. And so because these are wide complex QRSs and there's no atrial activity in front of them, you can infer that these beats are coming from the ventricles and that these are PVCs. And if you look, the QRS morphology is different for all of these PVCs. And so you could say these are multifocal PVCs. Because if PVCs were coming from the same focus every single time, they would look the exact same because the depolarization through the ventricles would be the exact same. They're not, so these are multifocal PVCs. So this person has a sinus rhythm. They've got a first degree AV block. They've got multifocal PVCs. And then the last thing that we'll look at is these normal QRSs here. You look, maybe we're starting to see we've got some big negative deflections in V1 and big upward deflections in V5. And certainly maybe for ventricular hypertrophy. And I'm trying to see if I can find these maybe 5, 10, 15, maybe 18 millimeter R wave in V5 and 5, 10, 15, maybe 16 millimeters S wave in V1. And so if you add those together, 16 plus 18, that is going to be 34 millimeters, so borderline, but not quite left ventricular hypertrophy. Around the board, I'm sure there are other criteria. Yeah. At the end of the day, this is just electrocardiographic evidence, and so borderline LVH. All right, so we're going to do some thing, regular rhythm. Our rate is 300, 150, 100, maybe 95 beats per minute. We've got atrial activity, and it's looking like there's some type of AV block because these P waves are coming pretty far away. The P waves are up in 1, they're up in AVF. This is a sinus rhythm. We've got every P wave conducts to a QRS. Every P wave conducts to a QRS throughout the strip. And this P wave, the time it takes for the P wave to conduct to the QRS, our PR interval is prolonged. And so this is a first degree AV block. Okay. Axis is up in AVF, up in 1. So I would say that this is going down to the left. It's a normal axis, closer to 0 if you see this is a little bit more isoelectric, so it's probably more like that, still down to the left. Otherwise, we still have normal R wave progression throughout. We've got normal T wave and QT intervals, and so this is a sinus rhythm, the first degree AV block. Okay. So here we have regular rhythm. Our rate here is going to be 300, 150, maybe 100 beats per minute. We've got P waves that are up in 1 and up in AVF, so this is a sinus, tachycardia. We've got, if you look at these P waves, which is interesting, is look how positive that is in V1. Look how positive that is in lead 2. And so a P wave that is greater than, I believe, 2.5 millimeters in lead 2. This is evidence of right atrial enlargement. So right atrial enlargement. So sinus tachycardia with right atrial enlargement. We said our PR interval looks good. So remember V1, that upward deflection in V1 is of the P wave. That upward deflection of the P wave in V1 is showing particularly the depolarization of the right atria. And the negative component of it is the left atria that depolarizes just a little bit after. And in between those two atria, Bachman's bundle, which is conducting the signal from atria to atria. And so we have a narrow QRS. In the axis here, it's down in lead one, it's up in AVF, and so we could say that it's going down to the left, and so we also have some right axis deviation. And otherwise, let's take a look at maybe what could be causing this right axis deviation, and maybe we'll check for right ventricular hypertrophy. We'll measure the R wave in V1. We've got say maybe 8 millimeters. So I would say maybe a little bit of RVH. Obviously, this is just on the EKG. So you'd have to confirm that with some type of imaging. And so if all the findings here, we've got sinus tachycardia, right atrial enlargement, right axis deviation, and maybe some borderline right ventricular hypertrophy. Okay. So we've got an EKG here. We've got regular beats until there's a gap. Regular beats until there's a gap. And so what's the first thing that comes to my mind when I see groups beating regularly with narrow QRSs? I think maybe there's an AV block. And so let's take a look. I see some P waves in front of them. Those P waves are up in lead one, they're up in lead one, and they're up in AVF. So these are sinus P waves. And then let's try to figure out, well, before this gap, you can see there's a P wave, and then there's no QRS. I don't see a QRS. So this must be some type of second degree AV block, because some of the P waves are conducting, but not all of them. So we need to figure out what type. And you can see that PR interval is getting longer and longer and longer and longer until it drops. And then it resets longer. So remember, the AV node has decremental conduction. And it gets worse and worse and worse with beats, usually when you're tachycardic. But here, this person has it at baseline. This is second degree type 1. So this is sinus rhythm with a second degree type 1 block. Now, we're going to start moving faster. This is going to take me forever. Go. So we've got a regular rhythm. Our rate is 300, 150, 100, 75 beats per minute. We've got P waves that are up in 1 and borderline AVF. But that's this P wave axis is straight down, so I'd call this a sinus rhythm. The PR interval looks good, so our AV node's doing good. Let's look at the QRS. Well, the QRSs are looking intense. They're very deep in V1, very deep in V2, very positive in V5 and V6. I'm not even going to count this. This is LVH, left ventricular hypertrophy. And then from there, we can say these are narrow QRS, and so it's still taking the normal conduction system. That would be LVH. And so this person is a sinus rhythm with left ventricular hypertrophy. Okay. We've already done this EKG, so we're going to pass. All right. So we get a regular, maybe not regular. Right? Look at that. Short gap, long gap, long gap, funky beat, long gap, short gap. Okay, so this is an irregular rhythm. And well, what's the atria doing? Well, if you look in V1, it's like almost looks like flutter waves, but they're not the same every time. And it's an irregular rhythm. I don't see any good P waves. So this is AFib, and this is actually what I would call like a coarse AFib, because it's almost a fluttery type. So this is coarse AFib. We've got narrow QRSs that are up in 1 and down in AVF. So we know that this is left axis deviation up and to the left. So our QRS is left axis deviation. And What else can we take a look at with this? Let's take a look at this funky beat. It's a wide, complex, and I don't see really, I mean, they're an AFib, so it's hard to say, but I'd say it's a wide, complex beat that occurs early. That's probably a PVC. I don't see any hypertrophy. I don't see any hypertrophies. This is coarse AFib with PVC. What is our response? 300, 150, 100. Yeah, all of these are likely less than 100 beats per minute, so it's not RVR. It's probably like a moderate ventricular response. And so let's take a look at this rhythm. This is going to be tricky for you guys. So we've got a regular rhythm that's occurring at 300, 150, 175. This will be 60. So maybe 65 beats per minute. It's a wide, complex beat. And so let's take a look at what the atria is doing. And is it driving this? And if you see, I've got some P waves that are sporadically kind of sprinkled throughout this. There's maybe some atrial activity that it's kind of hard to figure out what's going on. And if you look closely, you can see some little pacer spikes for these QRSs. So this is a pacemaker. And pacemaker always has wide, complex QRSs, and we often pace at the inferior portion of the ventricle. And so you should have negative QRSs in AVF as these forces are going up, and they are positive in lead one because they're going up and to the left. And most pacemakers are actually pacing the right ventricle. And so if you're pacing the right ventricle, that electrical activity is going to spread up and to the left. So that's kind of an interesting finding. That's normal. And the pacemaker is this is a ventricular pacemaker. And usually the ventricular pacemaker should be triggered by atrial activity so that it syncs. But if you look, these P waves, there's not the QRS that's being triggered right after. It should be being triggered maybe 200 milliseconds after, but it's not. So there might be something wrong with this pacemaker. This pacemaker might not be sensing these P waves, and that's what pacemakers are designed to do. Pacemakers have an atrial lead and a ventricular lead. So if this individual creates a P wave, which he did on his own, the pacemaker should recognize that and squeeze the ventricles so that we have some coordination, but it doesn't. So maybe this person needs to go see his cardiologist and determine what's wrong with the pacemaker. Why would they have a pacemaker? Well, there's probably an AV block, and obviously because his P waves are not conducting to a QRS, you can infer that he's got a third degree AV block or a very high degree AV block. So that's pacemaker rhythm. Alrighty, let's go through this. We've got regular rhythm throughout. We've got 300, 150, 100, so maybe 130 beats per minute. All right, we've got P waves in front of our QRS is less than 200 milliseconds, and so we would call this size tach. We're just going to cross through some rhythm strips right now. Okay, so we've got these beats, and then there's maybe an early beat. If you look at the time between these two beats, it's not right on time that we would say. It's a little early. And so you could say that this might be, if you look at the P wave morphology before that QRS, it's different from other P wave morphologies. And so maybe this is a PAC that is causing then the AV node to conduct that down to the ventricles, and we get a normal looking QRS. So maybe that's a PAC. Okay, here we have a rhythm that is very, very rapid, maybe 100 beats per minute. Call it maybe a wide complex, but don't even really, doesn't really have much of a form to it. And so we wouldn't really call this VTAC, we would call this VFib. Okay, so here we've got a regular tachycardia greater than 300, 150, so maybe 180 beats per minute. I don't see really any atrial activity that would tell us if this was maybe a ectopic atrial tachycardia. And so this is a narrow complex, regular, very regular tachycardia. So you can say this is a supraventricular tachycardia. We know that we would treat this with, they were symptomatic right this second and they needed some help, we could give them adenosine. And we could also shock them with sync cardioversion. And so really trying to reestablish the sinus rhythm. So it's interesting. All right, back to some 12 leads. So let's take a look at this. We've got QRSs. They look funky, but they're regular. So regular QRSs. And let's take a look and see what the atria is doing. We do have some P waves. And let's see, you can see the P waves are just positive in lead 1, positive in AVF. So this is a sinus P wave. Maybe a first degree AV block. If you look at the beginning of the QRS to the beginning of the P wave, it's borderline. If you look maybe right here in lead 3, it's borderline first degree AV block. We're not gonna call it though. And so let's figure out why this QRS looks so funky. Well, we see that the QRS is wide. So we think why QRS? Well, it's typically caused by conduction abnormalities within the ventricle. And so we see in the lateral leads here, we see this RSR prime, RSR prime, and we see it in V5, RSR prime. We see it in the lateral leads in lead 1, RSR prime. It kind of merges together, but that's an RSR prime. And so that, as well as these deep S waves that are slurred in V1 and V2 in the presence of a prolonged QRS. These are late forces in the lateral leads. So this will be a left bundle branch block. So this is sinus rhythm, left bundle branch block. So here we have beat, beat, funky beat, 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 beat. All the normal beats have P waves in front of it. All the QRSs are looking the same. QRSs are, I'd call them narrow. And then you've got this funky beat here. And so it's not a premature beat because if you look at the interval between this R and this R, this is happening kind of late. And so, well, this looks like a wide, complex beat. This is probably a ventricular beat. So we could call this a ventricular escape beat. And so it makes sense. We've got kind of a sinus pause. I see this P wave, but I don't see any P waves. So we have a sinus kind of delay. And so the ventricles decided to take over and say, I got you. And they went ahead and beat for it. So this is a pretty easy one here. We've got a rhythm that's being driven by the atria. Our PR interval, though, is very short. It's less than 120 milliseconds. And we've got this slurred delta wave. And so this was a Wolf, Parkinson, White. We know that slurred delta waves are because of pre-excitation of a communication between the atria and the ventricles that doesn't allow for adequate delay of that signal to go into the ventricles. And so we get a little slurry delta wave here. So this is Wolf, Parkinson, White. Okay. So here we've got narrow QRSs that are kind of ticking away, and then maybe kind of a quick tick here, and then ticking away. See if they're red. They look a little better, and so maybe this is a premature beat of some sort. Normal beats have P waves, normal PR interval. This one, it's very interesting. We've got this funky beat, but I don't see a P wave. You might ask, what is this little kind of pimple looking deflection there? And so This is actually a junctional escape beat. And the reason why is because if I drew a heart, and this is kind of interesting, here's my heart, and I'm going to draw my AV node right here, bundle of His and the bundle branches. If I had an escape beat that came from right here at the junction at the AV node, if I had an escape beat right at the junction, it would send the signal down into the ventricles like normal, but it would also send it retrograde up the AV node. And so what you're seeing right there is that retrograde atrial conduction, and it's happening almost at the same time as the ventricles, and actually right before, because it actually escapes up there faster than it does down the His-Purkinje system to create a QRS with almost the exact same morphology as the rest of the QRSs. So that's how we know that this is coming from the junction. It's very interesting. Okay, so we've got a regular rhythm here, and then we've got funky beat, funky beat, funky beat. And so, well, what's going on? We've got P waves in front of all of our normal beats. We've got normal AV node function. And then all of a sudden, I don't see P waves. I don't see P waves. And then I've got this wide, complex beat. So that's definitely a ventricular escape beat. I'm going to call it a VEB. But I don't see the sinus node taking over again. I don't see where the sinus node is beating and creating a P wave. And then we have another ventricular beat. And I don't see any more P waves. And then we got another ventricular beat. So it looks like there's some type of sinus arrest, which is when the sinus node arrests for greater than 3 seconds. And so we have these ventricular escape beats that are wide complex that are telling us that they're coming from the ventricles and they're not using the normal conduction in order to keep this individual alive. And so this person's normal heart rate was going at 300, 150, 100, maybe 120 beats per minute. And then this ventricular escape rhythm is maybe 300, 150, 100, 75, 60, 50, maybe 40 beats per minute. So we understand that that is a rate that is typical of a ventricular cell. Now we have a narrow QRS complex. I'm not sure this is perfectly regular. Get that compared to this. So you gotta be careful with if you say that it looks like it could be regular, but maybe it's not. Let's look at the atrial activity. I see an upgoing P wave here, a downgoing P wave here, another downgoing P wave here, a semi-upgoing P wave, but not as upgoing as our first, and then another semi-upgoing, and then gets back to a more upgoing, and then it's more flat. And so that's telling me that the P wave is coming from a different location within the atria and causing depolarization within the atria to conduct in different directions every single time. So this might be a wandering atrial pacemaker, or WAP. And that would make sense because the QRSs look the exact same. So the AV node is conducting signal in the same fashion every single time. But the beats aren't going to come with the exact same regularity because these wandering atrial pacemakers, they don't really care. So they're just going to beat whenever they're ready. And so this is wandering atrial pacemaker. All right, this rhythm, we've got P wave causing this QRS, P wave causing this QRS, P wave causing this QRS, and then we've got a gap, no P wave activity, and then we've got this narrow complex beat. We know that narrow complex beats are using the His-Purkinje system. And this one looks to be about the same morphology as the other ones that are coming before us. This looks like a junctional escape beat. And it looks like we have another junctional escape beat because there's no P wave activity in front of it. And then over here, it looks like that sinus node decided to take back over. And so right here, we've got two junctional escape beats. And if you look at this sinus, there's a little bit of sinus pause. And sinus pauses are any sinus pause that are less than 3 seconds. If it's greater than 3 seconds, it's a sinus arrest. But the sinus paused, and so then the junction decided to send some beats down the His-Purkinje system into the ventricles to keep us alive until the sinus node picked back up. And so this is a sinus rhythm with a sinus pause with two junctional escape beats. Okay. So here we've got a regular